which is focusing on prostate, and it is an honor for us to welcome Professor Razvan Galalae from the Klinikum of Bremerhaven. Thank you so much, Professor, for accepting our invitation, for being with us this afternoon. I give you the floor. If you share your screen, you will have full control of your own slides.
Thank you very much. So shall I share the screen and show the presentation from my laptop, right?
Yes, please.
So once again, thank you very much for the invitation to actively participate at this very interesting seminar, online seminar. It's an honor and a pleasure to be with you. I have two lectures. So in the first one, I would talk in general on heavy ion radiotherapy, so carbon ion radiotherapy for prostate cancer, and what it would be state of the art. Of course, it is not so easy to talk on state of the art and SIRT on for prostate cancer, because there is this is not a standard procedure for prostate cancer. So these are my disclosures. So I'm representing scientifically two institutions, Somed Austron Ion Therapy Center in Austria, and Christian Albers University Kiel in Germany, which is more leading institution in interventional radiotherapy. So these questions I would like to talk with you. For why carbon ion radiation therapy, radiotherapy for prostate cancer, which indications would be suitable for SIRT in prostate cancer, then what are actually the results published in the literature, and the lessons learned, and possibly future developments in this context. So carbon ions, as you know, are beautiful to use as a radiation oncologist because of the ability literally to stop the beam in a specific depth and to apply a very high dose at the level of the tumor, in the same time avoiding unnecessary radiation in the beam path proximal and distal from tumor. Why? So, but carbon ion radiotherapy has even more advantages than proton therapy, for example, because in the first part, in the beam entrance to the tumor, so proximal to the tumor, is low LET, and it's high LET in the tumor level where it is needed actually. So in the first part, so the proximal and also distal from the tumor, there is a high advantage physically over high dose photon radiation. And as you can see here, we have performed actually for the three main insurance companies in Austria in order to convince them that this is a good procedure. We performed in specific cases. For example, this was a 60-year patient with a high-risk prostate cancer treated locoregionally with high-dose SIRT, and we compared this with VMAT photons. And as you can see here, there is an additional dose in the bladder with VMAT photons of approximately 60%. Additional dose in the rectum of 64%, and also you see here in those volume histogram comparisons, the small bowel, the colon, the sigma, and even the urethra can be relatively spared with carbon. It's much better than with photons. So this would be a clear advantage over high-dose photon radiotherapy. And at the level of the tumor, there is even an advantage over proton therapy because the carbon ion beam is high LET and it has a radiological advantage over protons as well. As you can see here, the basic behind this is double break strands densely, so highly T densely deposited or performed, and radiobiologically there is a lot of data showing that even hypoxic tumors can be well destroyed with SIRT. In the case of prostate cancer, it's independent of the differentiation of the prostate cancer cells or the cell line, the Gleason score. Also, the fractionation effect is not striking, so it's a clear advantage of using highly hypofractionated protocols or ultrafractionated protocols, and also in highly mutated tumor cells, the cell killing is effective as well. So these advantages, radiobiological and physical advantages, are actually here summarized. So in low alpha beta tumor, of course, it's suitable to treat with hypofractionation. Also, photons with carbon ion makes even more sense, because the hypoxic tumor in this part of the in the treated tumors is very well, at least theoretically, addressed. The small spot size offer a small advantage, physical advantage, even over protons, but of course a large advantage over photons. The hypoxia or the carbon ion efficacy in hypoxic tumors is not, can be overcome. The carbon ion radiation can induce faster and better oxygenation, and there are some publications showing that after SIRT, the risk of second cancer might be substantially lower. So these are important advantages of SIRT, and it was our rationale to think about to use SIRT in prostate cancer. Of course, in Europe at least, so in Japan, SIRT for prostate cancer is established and is part of the recognized, also by insurance companies, recognized treatment options. However, in Europe, this is not. That's why we had to focus on specific risk groups. Just to remind you, the localized tumors can be divided in 3 risk groups: low risk, intermediate risk, and high risk, by using, as you know, PSA, Gleason score, and the T level of the tumor, the T stratification, and locally advanced tumors, so CT3 tumors, or CT4 even, or CN+, can be considered a very high risk or locally advanced. So these were actually the tumors we were focusing on. When comparing the results of at long term of high dose radiation in prostate cancer, and we compare by risk classes the conventional radiation with SIRT, you can see here that in low risk there is no real advantage for SIRT over classical, for example, high dose rate IMAT or VMAT, or brachytherapy, but it is a small advantage in intermediate risk, favorable intermediate risk, and it is a clear advantage in high risk or high risk. Then here you can see in low risk, actually low risk prostate cancer, that the HDR and LDR monotherapy are hard to beat. So also for us was a clear sign. This is the same situation in intermediate risk, in favorable intermediate risk. So we thought we should concentrate on higher risk prostate cancer. And the best level 1 evidence in the conventional world, let's say, is represented by a standard trial in the combo arm of photon-based IMRT of whole pelvis with a brachytherapy boost. And you see here that on the left side that the high risk, unfavorable, intermediate risk long-term results at 5 years are 84%, so actually excellent. And but with some caveats, the association with with high-grade toxicity was there. So GI 3.2% and GU 5.2%. And in this trial, we could also see clinically significant decline in the mean scores of physical role and sexual function in the health-related quality of life of the patients. And in contrast to these data, which I think can be considered in the high-risk cohort of prostate cancer the best in the conventional world, we can see on the right-hand side the long-term results from the 6 institutes in Japan are even better, especially in intermediate risk and in high-risk prostate cancer, with results over 90% at 5 years and nearly 80% at 10 years. And in addition to that, nearly 0% grade 3 toxicities, which is, of course, also excellent. Published in British Journal of Cancer in 2014 and the standard trial in Red Journal in 2017. By creating for Europe a CIRT protocol based on evidence-based medicine in the literature, it's clear that we should focus on at least high intermediate risk, high risk, and the very ugly here, salvage radiation, so rare radiation, for example, T3, T4, and plus, and limited metastatic disease. In the good indications, so meaning low risk prostate cancer, low intermediate risk prostate cancer, of course, here is still dominating the radical surgery, the scene, and the alternatives, which we just discussed, are actually brachymonotherapy, IMRT, VMAT, high dose, and also SBRT. The alternatives in particle therapy, I would see here protons, and in very special indications like small bowel in contact to prostate, pelvic pre-radiation, or genetic syndromes with increased radiation sensitivity. For example, here a small list of those genetic syndromes. I have, for example, personal experience with ataxia telangiectasia, so ATM syndrome. And when verifying the dose escalating trials, comparing dose escalation to up to 80-day EQD2 versus conventional doses, from the major trials performed, only the proton trial was actually able to show a clear benefit in biochemical control of 20%, but without added toxicity in the treated patients, meaning all the other phase 3 trials actually demonstrated an increase of high-grade toxicity up to 14%. So this is actually level 1 knowledge. And from these trials, we also know that all risk strata actually in prostate cancer do benefit from a dose escalation. However, of course, the higher risk prostate cancer do benefit more. So concluding this old evidence is that yes, dose escalation is needed for all risk strata in prostate cancer to about 80 gray AQD2. But to do that with protons, this is level 1 evidence, is not associated with high or increased toxicity. However, as I said before, so in Europe, it's difficult to use particle therapy in low-risk prostate cancer. Also, lessons learned can be mentioned by the ultra hypofractionation performed with HDR brachytherapy up to, as you can see here, up to 81 gray in the entire prostate and up to 130 gray in the peripheral zone of McNeil in AQD2. From this experience, we have actually learned that above the level of 80 gray of what we consider dose escalation, the dose intensification up to or higher than 90 gray would add more benefit in the higher risk prostate cohort. We have published that from the Kiel group together with the Martinez Alvaro group from Beaumont Hospital in the USA in 324 hormone naive men treated with this very high dose intensification over 94 gray in AQD2. And you see here that the benefit was striking up to 85 gray of 5-year, 85%, sorry, of 5-year biochemical control versus 60%. In this context, we could also demonstrate that when patients treated with these very, very high doses above 95 gray, that the nadir reached after treatment in the 18 months after treatment, so nadir PSA 18 months, it becomes surgical at lower than 0.5 nanogram per milliliter with increased biochemical control rates of 5 years at 5 years of about 90% versus 78%. In addition, in these very high dose protocols, it's important, of course, to also, we saw that in a standard trial, to avoid and lower high-grade toxicity. And one possibility is to use rectal spacer. For example, in this trial in USA, in a randomized trial from USA, using 79 gray IMRT plus minus spacer with a lowering of higher graded GI toxicity from 9% to 2%, but also by helping to distribute the dose differently in the prostate, also to lower actually the urinary toxicity. Here are actually the 3 main publications according to this important trial. We should also, by reviewing the lessons learned, to talk about possible future developments. Another possibility in the future, but also actually already introduced, is to use the next generation of hydrogel spacers, which are not only visible in the T2 weighted MRI, but also in the computed tomography, offering, for example, in a cone beam CT, also visibility and the possibility of matching not only on the gold markers, but also on this next generation hydrogel. Then the one point is that we also saw clearly in the Japanese data that the long-term data show actually very excellent local control. So the local control is somewhere around 1%. So this is very difficult to optimize. However, the distant controls and control on distant mets is also high, over 90%, but this is more significant than the local control. This is especially the case, of course, in high-risk prostate cancer, meaning that it's important to also talk about how to, in the future, how to diminish actually the rate of distant mets. One possibility is, of course, as the Japanese data showed, to use, and their standard trial also, to use added ADT for 2 years. Also, a possibility is, especially in very high-risk prostate cancers with N+ disease, we use ADT also in Terona on top of the ADT, of the classical ADT. And another possibility is to use in situ vaccination, and this can be created, for example, by a new brachytherapy source which is emitting alpha radiation, which is of course also high LET radiation and causes multiple DNA breaks and cell death, so direct cell death, similar to carbonine radiation. Here, very interesting publication by the group of Professor Keisari from University of Tel Aviv, by using this alpha emitting brachysource. You see here the decay chain from radium-224 to lead 208 at the end, with multiple decay elements emitting alpha radiation within a time of about 2 weeks. These are how these sources look like, and these can cause in the animals treated by a DART a resistance to a second tumor challenge, which speaks clearly for abscopal effects. And this group has also learned to modulate those abscopal effects by, as you can see here, by immunoadjuvants like CPG, and by adding these immunoadjuvants to prolong even and to make it more pronounced, this abscopal effect on distant tumor as well. And it is also in Frontiers Oncology, published in 2020, a very interesting finding in not in prostate cancer, but in pancreatic cancer and in triple-negative breast cancer, that animals with lung metastatic disease can be cured by local treatment of DART, alpha radiation, with immune modulation in order to 70%. And I think this fits very nicely to for example, to SIRT, and that could be used as an upfront procedure prior SIRT in very high risk prostate cancers, but also in oligometastatic disease. So when reviewing the potential benefit of particle therapy for prostate cancer, we can actually summarize that one possibility is to increase the radiation dose to the target volume. And in my second talk, I will show you later on what would be the meta-ostron procedure, how to reach that in order to improve local control and, of course, survival. But in the same time, to reduce significantly side effects, even so, not only by reducing the dose in the rectum classically or in the bladder, but also relatively in the urethra. And the use of highly T particles like carbon ions, of course, can improve local control survival even in radio-resistant tumors, and can possibly replace mutilating surgery, for example. So I would like to summarize in this first talk that particle therapy in general, so protons and carbon ions, competes with photon-based radiotherapy and also radical surgery, classical indications in low risk and favorable intermediate risk prostate cancer. Particle therapy can reduce side effects and has the potential to improve local control. For the first effect, so reducing side effects, we have level 1 evidence in one phase 3 trial. And then carbon ion therapy can improve local control and biochemical control in and along with avoiding toxicity in specific prostate cancer indications in very high risk and unfavorable intermediate risk, but also as radiation or salvage radiation radio-resistant tumors in the pre-irradiated prostate. I will show you some cases in the second talk. Of course, here we have no head-to-head comparative trials, phase 3 trials. I just showed you the long-term Japanese results, which are excellent, and I would think the reference, not only in Japan, but in worldwide, with the Astende trial, the combo arm, which can be considered the best in the conventional world. However, phase 3 trials are difficult to conduct, but I think they should be designed in a collaborative setting and also performed. We are actually talking now with colleagues from USA and trying to really design a phase 3 trial in specific prostate cancer indications, protons versus carbon ions and versus high dose photons, SPRT. So thank you very much for listening and for the attendance. I would be ready to take questions for this first talk.
Thank you so much, Professor Galalae. We have one question for you on the Google form. How is prostate movement managed daily? CBCT and MRI. Adaptive planning is performed.
Yes. So I will show that in the next talk, but I can answer the question. So first of all, when using these hydrogel spacers, there is already a fixation of the prostate toward os pubis, that helps by diminishing especially the APPA movement of the prostate. That's important. Second, of course, we have daily match of so prior each radiation of the gold markers, and as I showed you, possibly in the future also hydrogel, which is visible in cone beam CT. We also use daily cone beam CT in the first week, and at day 4 we also replan, actually do another CT plan and replan the entire plan in order to have robust planning. And what we also do, I will show you next talk as well, what Piero Fossati mentioned also, we also have robust calculations taking into account all possible movement, but also density differences, for example, in the bowel. And we also calculate both with the Japanese model and with the European model, the dose distribution, in order to have more robustness. So these are our tools to create as much as possible robustness in this 12 fractions treatment.
Thank you so much for your answer. Do we have any more questions? Okay, no more questions. Professor Galalae, it was a really pleasure and honor, in fact, to have you here with us.
Thank you very much.
Yeah, I have just one last question. Prostate cancer being so so common, what is keeping insurance companies from covering this type of therapy? Is it and is it the reason that trials are not yet fully confirmed at the 3rd stage? And is there a European or possibly even international effort in pooling resources to perform such clinical trials to prove that such therapies are in fact effective?
Yes. So thank you very much for this important question. It's indeed very, very difficult to answer it, let's say, as a valid answer for entire Europe, because the insurance companies, for example, in Germany, in Austria, and in other countries act differently. So in Austria, there are 3 major insurance companies, and they are actually very well linked, and also all 3 are well in discussion and in, let's say, in idea exchange and brainstorming with MedAustron, with the specialists at MedAustron. That's good, and that's important. And we have actually in Austria a clear, let's say, compromise that we say all indications, especially for prostate cancer, to be considered for payment with particle therapies, especially carbonine, by one of these 3 insurance companies in Austria. All these patients have to pass first a tumor board, right? So a tumor conference, independent from the specialist at MedAustron. So we would say this case is suitable, and I showed you what would be the suitable cases from our point of view. So the very high risk cases, actually, and then the colleagues at the tumor conference, independent of us, would decide and confirm this or disregard our proposal. So this is the first step in Austria. In Germany, it's more difficult because there are over 300 insurance companies, and they are very, very, very different. That's difficult to have an agreement with those. But the most, of course, the Japanese data are the basis of discussions, because they are now published at 10 years and 20 years. And the important thing in the Japanese data is that they are not single institution data. They are not randomized, yes, but they are actually produced by all 6 institutes over decades now. No? So they actually moved from 16 fractions to 12 fractions. And this is what we also actually, it was the base of our work to take, as Piero Fossati explained to you also in Cordoma, to actually translate these doses from the Japanese model to the European model. But we have done, I will show you in the next lecture, some things differently. So we actually took some knowledge from brachytherapy and implemented it. And also we treat lymph nodes. So not only involved lymph nodes, but also, prophylactic. So this is, I think we are the first to do that with seared high dose at the pelvic wall. And we actually could demonstrate it's not toxic, so we can do it. However, especially the non-Austrian insurance companies in Europe, they would expect from us to conduct a randomized trial. No? And this is not as difficult, not only ethically, but it's also difficult because, of course, not every country has the possibility to treat carbon. I think treat photons, SBRT or brachytherapy. There are many specialized institutes in Europe. I think Europe is leading, and the US as well. Protons, there are some possibilities all over Europe, but carbon ions. So we are talking, for example, now with our colleagues in USA, if we would randomize, for example, an American patient to carbon ion therapy, they would have to send us the patient to Europe or to Japan, no? In order to be treated in a trial. So that is the limitation in the moment. No? So we have, I would say, the luxury position that we can treat in Austria with each beam. No? So that's a luxury position to treat prostate with everything. But and to answer the last part of your question, we wanted to be, of course, fair to the insurance companies and don't offer this expensive treatment to low-risk prostate cancer. Now, because I showed you the differences at long term are minimal, if any. Yeah. So in low risk there is no difference actually. So in my opinion, HDR monotherapy or seeds are actually very easy to perform in many institutions. And IMRT high dose, but starting with unfavorable intermediate risk, and the very end of high risk would be N+ disease. Yeah, so I think there I am quite convinced that carbon ion therapy can make the difference. Yeah, even versus protons. However, we don't have a head-to-head clear level 1 evidence, and I am also convinced we have to create that, despite these problems of availability of all these treatment options. But I think we have to do this effort, in a significant number of patients to prove a difference, if any. And I am happy, and I am also quite sure that the Japanese colleagues will join, and also the US colleagues, even though there is no carbon ion therapy in USA in the moment, they would like to participate. We have really very, very good discussions. We also, at the last PTCOG in Madrid, we had already an update of these discussions, and I hope I can let you know maybe next time that we have actually initiated this trial. But in the moment, it's just a plan. Yeah.
Professor Galalae, thank you so much for your very detailed reply. We will now take a coffee break. Before the coffee break, I urge all participants to answer the poll question, please. After the coffee break, at 4 o'clock, we will have Roberto Orecchia from the IEO, who will discuss trial design. And after that, at 4:45, we will meet Professor Galalae again, and he will show us a case study on prostate. So we take a short break and we will meet again at 4 o'clock. Thank you very much.
Nicholas, if I may add also,
Yes.
I would like to remind to our participants that today at 6 p.m. we are going to have the career fair, and we are going to have scientists or the respective persons from Medastron and Now. So we're looking forward to meet you there.
Thank you very much, Elpida, for
We
that
are going.
reminder.
Thank you. We are going to put the appropriate links in the chat. Thank you.
We have had very good feedback from these networking events in past courses, and I encourage all of you to consider attending. We thank the speakers of this session, and now we take a short coffee break. We'll meet again at 4 p.m. Thank you.